Hello and welcome to today's seminar, Using Health Data to Develop Gender-Responsive Policies. This is the sixth in our 7-part series on gender foundations in health data. If you don't know me by now, I'm Dr. Michelle Kaufman, the lead for the Gender Equity Unit of the Data for Health Initiative. I hope you enjoyed our opening music by female artists from Algeria, South Africa, Brazil, and Benin. Today's seminar will build upon the last one about gender data analysis so that we can learn how countries use these analyses to develop health policies that reflect gender equity, inclusion, and responsiveness. Vital Strategies is the organizational leader and partner of choice when using data to develop policies for global health impact. They will be sharing excerpts today from their Data to Policy course, in particular a new module on gender analysis that was developed together with members of our Gender Equity Unit. The combination of expertise in health data and in gender integration is powerful, and we hope you can learn from the examples presented of how to create gender-responsive policies to improve the lives of women, girls, and gender minorities in your own work. Now, I'd like to introduce our moderator for this session, Jo Ali, who is a member of the Data for Health team at Johns Hopkins. Jo is an assistant professor of international health and the associate director for global programs for the Johns Hopkins Berman Institute of Bioethics. His research engages a range of challenges in global health ethics and includes empirical and normative work to address the implications of emerging global mobile and digital technologies as applied in the context of health research, public health programs, and disease surveillance. At Johns Hopkins, Jo serves as a member of the Institutional Review Board and the school's Faculty Senate. He has been involved in establishing and operating NIH-funded non-degree master's, doctoral, and postdoctoral training programs in bioethics at Johns Hopkins and with partners in Uganda, Ethiopia, Zambia, Botswana, and Malaysia. He earned his JD at the University of Pittsburgh. Jo, so thankful that you could join us today, and welcome.
Thank you very much, Dr. Kaufman. It's a pleasure to be joining everyone today. Hello and good morning. So as Dr. Kaufman mentioned, my name is Jo Ali, and I'm delighted to be moderating this panel today. The agenda for this seminar will follow a traditional format. We'll be hearing from each of our panelists in turn, and then we'll have select questions from the audience. We'll start with a joint presentation by Dr. Ruxana Jina from Vital Strategies and Dr. Stangl from HERA Solutions. They'll be presenting a customized module from the Data for Health data course called Using Data to Develop Gender-Responsive Policy Solutions. Next, Dr. Fatima Marino, a Senior Technical Advisor at Vital Strategies, will share examples of using multiple population-level data sets in Brazil to conduct a gendered analysis that could be used to change country policies on gender-based violence and adolescent pregnancy. After Fatima's presentation, we'll take select audience questions. So let's get started by introducing Dr. Ruxana Jina and Dr. Stangl. Ruxana Jina, known as Roxy, is the director of the Data Impact Program at Vital Strategies. She's a public health medicine specialist with a master's degree in epidemiology and a PhD in public health. Ruxana has over 15 years of experience in epidemiology and public health practice, holding multiple positions in the public health sector in South Africa. Her previous roles include heading an epidemiology unit at the National Institute for Occupational Health and working in management at Charlotte Maxeke Johannesburg Academic Hospital and the Auditor General of South Africa. Roxy has a personal interest in women's health, focusing specifically on gender-based violence and health. Dr. Stangl is a social and behavioral scientist and president of HERA Solutions, an independent firm providing research and advisory services to organizations, companies, and governments to strengthen health equity. Anne is also associate faculty with the Department of International Health and the Johns Hopkins Bloomberg School of Public Health. She has 21 years of international public health experience in Africa, Asia, and the Caribbean. Her research focuses on understanding and addressing the social determinants and structural determinants of health, including intersectional stigma that impede access to and uptake of health services among underserved populations globally. She is also actively engaged in utilizing research findings to inform global policy and action. She holds a PhD in public health from Tulane University. Welcome, Roxy and Anne. You have 25 minutes.
Thanks very much, Joe. So as Joe mentioned, today Anne and I will be presenting on how the Bloomberg Philanthropies Data Impact Program has incorporated gender analysis for policy development in the Data to Policy program, or what I will refer to as D2P. Next slide, please. So firstly, for those of you who are not familiar with the D2P program, let me provide you with a bit of background. The objective of the program is to improve the use of data in public health policy by strengthening the analytic capacity within government agencies to produce evidence-informed policy recommendations. So just to clarify what Michelle said at the opening, the program is actually a collaboration between Vital Strategies, the US CDC, and the CDC Foundation. And several people from all of the organizations have been involved both in the development and delivery of D2P. Next slide. So in the program, we use a systematic approach for using data and evidence in policy development. So we think of this as a link between public health professionals who can conduct data analysis and use data to develop strong policy recommendations, and then the policymakers who are actually making policy decisions. Traditionally, D2P is implemented as a structured, intensive training program whereby teams of government staff are capacitated to make evidence-based policy recommendations through training and mentoring. These recommendations are then captured in the form of a policy brief that is presented to decision makers for further action. So the aim is to institutionalize this approach and the curriculum through training of the trainer programs and also by embedding it within the policy development processes in government. Next slide. So during the program, we guide teams through the steps for describing a policy problem, identifying the causes of that problem, defining and assessing policy options or interventions, and then making a very persuasive policy recommendation. Our curriculum, as you can see in the purple blocks at the bottom of the slide, provides the underlying theory for each of these steps. And then we work very closely with government teams to implement the concepts on the particular policy topic or specific policy topic that they are working on. Next slide. In terms of implementation, we have delivered 26 trainings across 15 countries, through which more than 110 policy briefs have been developed. About 50% of these have already led to some change in policy or practice. And this figure may obviously increase because we know that policy change can take time to be enacted. Over 450 government staff have been trained, and more than 50% of these have been female. And in 7 countries, there are plans to institutionalize the approach with local facilitators to lead the program. Next slide. So over the years, we have been continuously looking at the D2P program and thinking of ways to improve both the delivery and the design of D2P. Firstly, as a result, we have broadened our approach for sharing the methodology with government agencies. So in some instances, a structured training program may not be the most suitable, based both on the existing needs of the government, but also the existing capacity that they have. So in some situations, it may be better to connect with a specific unit or division in government that then is responsible for either policy or planning. In such situations, we would focus more on the mentoring, even though we may do some training as well, and also review the systems, tools, and processes. In another setting, we could share the D2P approach through mentoring a smaller group of participants as proof of concept to show that it actually could work in very specific settings. Secondly, we also have recognized the challenge of implementing a very intensive in-person training model for government staff. And we were already in the process of working on a hybrid model for delivery when the pandemic started. This accelerated our efforts, and not only have we started developed online material to supplement our instructor-led training, but have also developed versions of the material for virtual delivery. Thirdly, in terms of our curriculum, we constantly review and improve our materials. This may be in the form of new examples, new exercises, and recently we've also been looking at the language and the content to ensure that it's inclusive and reflects the countries that we work with in terms of diversity and the experiences within these countries. And finally, we identify gaps in our material and seek to address these where necessary and feasible. So recently, we've been reflecting about how gender is addressed in the policy brief development process. And there are instances where we had policy recommendations in the past having some gender implications, but we've never systematically included this as part of the D2P program. Next slide. To address this gap in the policy process, we have now developed a specific module on gender analysis for policy development. And this was done by a colleague in Myanmar, Tay, with other colleagues in the Data Impact Program. And we are now working with colleagues in Johns Hopkins University to review and improve it. In addition, we are reviewing the entire D2P curriculum to identify if there are other areas where gender could be integrated into the content. And we are also developing applied exercises and thinking about whether gender could be considered early on in the process when we actually are defining the policy topics. So I'll now pass on to my colleague, Anne, who will take you through some of the key content from the gender analysis module that I mentioned. Thanks.
Thanks, Roxy, and good morning, everyone. One of the first things we review, next slide, I should say. One of the first things that we review with the trainees is how gender affects health status. So I would like to start here today. First, there may be differences in the etiology of illnesses between men and women. So how people get sick and how disease progresses. We note that certain diseases affect men more than women and vice versa. When we think about exposure to risk factors, in certain conditions, men and women are exposed to different risk factors or have different levels of exposure. So for example, women in developing countries may have a higher exposure to wood smoke from cooking fires than men, which may lead to a higher prevalence of respiratory issues among women. So we can also think about the social determinants of health from a gendered perspective. For example, levels of poverty may affect men and women in different ways. Second, gender can also affect how illness is treated. So there could be differences in access to treatment resources and services between men and women. For example, women may be more likely to visit clinics for diagnostic services than men. But once at the clinic, women may receive substandard care compared to men due to gender bias among healthcare providers. So these are often subconscious gender biases that see men as silent stoics and women as hysterical hypochondriacs, which can lead to women's concerns about pain or symptoms being taken less seriously and therefore treated less effectively than men's. So another way that gender affects treatment of illness is that medical research is often based on men or male biology. And this can lead to medical guidance, drugs, and technology that are tailored more to male biology. Third, gender also affects the provision of care. So for example, in the home, who is responsible for caring for ill family members? Often that responsibility lies with women and girls. In addition, power dynamics in a relationship often leave men in control of decision-making about when family members should seek healthcare services. And lastly, healthcare facilities are not always welcoming to all genders. So for example, if a receptionist at a clinic refuses to call a transgender person by their preferred name during check-in, this experience of stigma can dissuade the person from seeking care in the future. Next. So in terms of policy design and implementation, we need to think about who influences the policy agenda, who is deciding what the priorities are, and how the policies are developed. Another way we can think about how gender affects policy is cultural, social, and economic factors that affect the policy environment and implementation. So for example, you may have a progressive family planning policy in your country or region that includes access to contraception and abortion services, but if the healthcare providers in the country or region have strong biases against women's access to and use of such services, the implementation of the policy may not be very effective. So related to this, the structure of the health workforce also matters. So are there equal numbers of male and female general practitioners and specialists? Having a gender balanced health workforce can help to ensure that gender sensitive or gender responsive health policies are implemented. Next. So policies range from gender reinforcing, for example, health system policies that reinforce patients' traditional gender roles and neglect inequalities in health, to gender transformative. So for example, ensuring that women are equally represented in all the health workforce at all levels. So in order to ensure improved health outcomes for all, we must tip the scale towards gender equality by prioritizing policies that respond to and seek to transform harmful gender norms and behaviors that heighten health risks and make access to care more difficult. Next. So let's take a closer look at each of the categories and consider some examples. At one end of the spectrum, we have policies that are gender reinforcing in that they reinforce harmful gender norms or roles. So for example, the belief that men, should be in control of financial resources and decision-making. An example of a gender reinforcing policy is one that excludes women from having a health insurance policy in their name. So next, we have gender neutral policies that do not recognize any gender differences. So for example, a policy that assigns user fees for health services universally might unintentionally limit women's access to health services if women have less access to disposable income in a given country. So it's important to note that many policies might appear gender neutral when actually they are gender reinforcing. So for example, many policies target general populations such as youth or smokers, but they may actually be designed based on the needs and preferences of men and boys. Next. So then there are gender sensitive policies that acknowledge gender norms, roles, and inequalities, and often raise awareness of these issues, but do not necessarily take appropriate actions to address them. So for example, a policy that mandates the collection of gender disaggregated data on public health outcomes, but not the use of such data. Next, we have gender responsive policies that consider and take specific actions to respond to the gender norms, roles, and inequalities that impede health services. Gender responsive approaches take gender-related drivers of health risk and gender-related barriers to health services into account in their design, implementation, and evaluation to ensure that health services are reaching people of all genders. An example of a gender responsive policy would be the creation of separate outpatient areas at clinics that are run by women doctors for reproductive health services. And finally, we have gender transformative policies that seek to fundamentally change the social and gender norms, as well as the structures that fuel gender inequalities in order to address the unequal power dynamics that heighten women's, girls, and gender and sexual minorities' risks for poor health outcomes and limit their access to health services. So for example, a policy that redistributes resources and power to ensure equitable outcomes. Next. So we've talked about how gender influences health outcomes and the policy environment. So now let's talk about how we can use gender analysis to ensure gender equitable health policy. So gender analysis examines the difference and disparities in the roles that men and women play, the power imbalances in their relations, their needs, constraints, and opportunities, and the impact of these differences on their lives. It looks at how gender is present or absent in policies. Gender analysis also examines similarities, as it is important to understand if risk factors are the same for men and women, for example, in which case the policy recommendations may not need to differ by gender. Next. So insights from this analysis can then be applied to policy development and service delivery. So without gender analysis, important gender considerations could be missed in policy development. And as a result, policies may not achieve their intended objectives. Next. So let's look at a quick example of how gender analysis can be applied to a specific policy area, tobacco policy. So we know that tobacco smoking affects men and women differently. So for example, in many cultures, smoking is seen as a masculine behavior. So men often smoke at higher rates than women. But let's think about how specific policy areas might have different implications for men and women. Next. First, taxation. So women may have access to less disposable income. Of this, increases in tobacco taxes might affect women's tobacco use more than men's. If men are more likely to smoke in a given society, taxation may not have the desired effect of reducing smoking. Second, secondhand smoke. Women who are non-smokers are more likely to be exposed to secondhand smoke, and this may require education targeted to men about risks to their families. Third, programs targeting pregnant women. So some programs designed to prevent harms of smoking during pregnancy can disregard women's need for support, focusing only on the health of the unborn child. So it's important to think about how to balance communications about the risks of smoking during pregnancy with support for women to help them quit. Next. So when is the best time to do gender analysis? Next. So gender should be considered throughout the entire policy development and implementation cycle. So we're going to take a look now at what a gender-sensitive policy process would involve. And just to note here that the trainees in the course are introduced to the policy lifecycle diagram that you see here in a previous module on public health policy. So they're already familiar with each of these steps and what they entail. In this specific module, we're focusing on how gender analysis can be integrated into each step. So obviously, gender analysis is critical when defining the problem. So to get this right, active engagement of all genders is needed to inform agenda setting and problem definition. Next. Engagement of all genders is also needed when constructing policy options based on the gender assessment findings. Next. In order to select the preferred policy option, it's important to ensure that gender analysis findings are integrated into the policy analysis process. Next. Policies should be gender sensitive at a minimum, but preferably gender responsive and/or gender transformative. So during that policy design phase, it's really important to think about how we could be making policies more gender sensitive or ideally gender responsive. Next. So during policy implementation, it's important to pay attention to how women and girls, gender and sexual minorities, and men and boys are involved in or affected by the policy. Next. And finally, data disaggregated by gender, not just sex, should be used when evaluating and reviewing a policy to assess how policies affect the lives of men, women, and gender and sexual minorities. Next. So these are some of the types of analyses trainees work on during the D2P program. On this slide, we include some suggestions for how to incorporate gender analysis into these steps. Next. In describing the problem, we can look at gender differences in the burden of the health problem, especially among subpopulations of men, women, and sexual and gender minorities. Are there any data to elucidate how differences between men, women, and sexual and gender minorities are impacted by other dimensions such as age, geography, urban, rural residence, income, and so on? For the root cause analysis, we may want to explore how gender differences, norms, and disparities shape root causes of the identified health problem and how they affect exposure to risk factors, response to illness, or access to services. Next. And for policy analysis, we can look at how gender is shaping the current policy environment and past policies. We can also analyze how the different policy options might affect health, economic, and other outcomes for men, women, and sexual or gender minorities. And finally, we can consider how policies can help to address or counteract some of the unequal gender norms and power relations that influence health outcomes and lead to disparities. Next. So we've now piloted this module in 3 country trainings over the past 5 to 6 months. And based on those experiences, we're considering ways to reinforce the lessons in the new module and provide additional support to trainees to fully integrate these lessons into their policy work. So just as some examples of what we've been thinking about are further integrating gender throughout the training modules and providing more examples where gender is a factor and should be considered in policy development, engaging the training teams prior to the start of training about planned topics and encouraging them to consider gender early on, offering support to training teams between the training modules to integrate gender analysis into the policy lifecycle, and training local D2P gender focal people to continue to provide support in country for integrating gender analysis into policy development after the training is completed. So now I will turn it back over to Roxy to provide some relevant examples. Thank you.
Thanks, and next slide, please. So Anne described some ways in which gender can be considered in the policy development process. However, we know from experience and reality that this does not always happen, even when gender may be extremely relevant to the policy topic. So as an example, in 2017, a review of non-communicable disease prevention policies in South Africa found that gender was not always discussed, even when it had implications for policy implementation, as reflected in this quote on the right-hand side, which is presented on the formulation of salt reduction regulations. Next slide. And we can see that more recently, the Ministry of Health has been trying to address this by making a concerted effort to include a gender lens very specifically when drafting their new national strategic plan for the prevention and control of non-communicable diseases. So we see this on the table in the left, where they have a very specific column around gender and the gender approach. However, we notice that these efforts are being lost in newer versions of the document. So for example, the text on the right has replaced the table in an updated version of the document. And in another version that I found online, but haven't shared because it still has some internal comments on it, and definitely looks like a newer version of the document, shows that even this language that appears on the right has now been removed. Next slide. And in another example from Tanzania, we see researchers from Muhimbili University who reviewed and assessed policies and practices related to the prevention of mother-to-child transmission programs of HIV. So the authors found that although the role of gender was acknowledged in policies and strategies, as we see on this quote on the right-hand side, that's from the National Guidelines for Comprehensive Care of PMTCT and Keeping Mothers Alive, which, if you go back to Anne's presentation, would maybe be considered to be gender-sensitive policies. The documents or the policies or strategies really fail to then address these sort of issues and include remedial actions or interventions. So the authors speculated that this may be explained by the fact that in the design stage of the policy or strategy, gender is often handled as an add-on, but not really seen as an integrated part of the entire policy process, that cycle that Anne presented. And the reason for this may be that the need to integrate gender is often addressing sort of external concerns or external requests, as opposed to really being seen as a priority within government. However, they also speculate that there may be limited capacity in gender mainstreaming among policymakers, which may also play a role. So in summary, the efforts that we have made to incorporate gender in the D2P program may not address some of the challenges that I now highlighted in the South African and Tanzanian example, but it provides an entry point to start having these discussions. And I think an important element as we work on this would be to ensure that gender is recognized as an important factor by government partners themselves, as opposed to being seen as an external priority that we are enforcing on them. And with that, we ended our presentation. Thank you all. And Joe, I'll hand it back to you.
Wonderful. Well, thank you very much, Ruxana, and for laying the foundation for this seminar by describing how to use gendered health data analysis to develop responsive policies. I'd now like to introduce our next speaker, Dr. Fatima Marino. Dr. Marino is a national of Brazil and currently working as a senior technical advisor at Vital Strategies and a professor of public health at the Federal University at Minas Gerais, Brazil. She has been a coordinator of epidemiological analysis at the Brazilian Ministry of Health, responsible for vital statistics systems. She has also held positions at the Pan American Health Organization, or PAHO, coordinating the Information and Health Analysis Project. Fatima obtained her degree in medicine from the Federal University of Rio de Janeiro and then completed her medical residency, a master's of public health, and a doctorate in preventive medicine and epidemiology at the University of Sao Paulo. Welcome, Fatima. You have 25 minutes.
Thank you, Joe. It's a pleasure to be here. And I will talk about an experience of gender-based violence surveillance. It is a public policy established for some years. Next, please. So in Brazil, the Ministry of Health, after some years exploring causes of deaths or unknown causes of death, we started to create a violence and injury surveillance systems. It was implemented officially in 2011, but before it, we piloted this system. We started in 2006 with these pilots in health centers and some emergency rooms. In 2009, reported violence case registered in the notifiable disease and injury information systems. And in 2011, it became mandatory for all public and private health services. So with this, we implemented an information system based in violence or other injuries or even diseases of women living under domestic violence. Next. So violence and injury surveillance system, we call SINAM. Now, this system reports suspected or confirmed cases of violence against children, adolescents, women, elderly, people with disability, indigenous, LGBT populations, and so on. So types of violence described here, so gender-based violence, domestic, sexual violence, self-inflicted, human trafficking, slave labor, child labor, torture, and so on. Data disaggregated by age, local, race, sexual option, type of violence in perpetrator, etc. So we can disaggregate it until the municipality level, also until the small area level. Next, please. So during this time, 2011, 2017, health services reported almost 1.5 million violence cases. Among those, 1 million were women. So in 1 million, almost 1.5 million, no cases reported, we found that sexual violence was more prevalent among children and adolescents. And also children were around 219,000 cases and 372,000 cases against adolescents. But we focus in this first approach in sexual violence, and you can see that the children and adolescents, probably because of they come to health service and pediatricians, they pay attention on it. So next, please. So here we started to describe it. Notice violence, profile notification of violence and death of women from external causes in Brazil. 70% reported violence occurred at home, 90% on public roads. Of 73% reported violence were committed against children were perpetrated by a family member. 63% of reported violence was the physical type. 40% notification were of self-harm, being higher among elderly women. And 28% were characterized as repeated violence. Next. Here we are approaching the sexual violence. Okay, so female adolescents rape. We separate in two age groups. You see, because we have more cases reported, of course, it's a reported case by health services. Okay, so we have more cases between this age group, 10 to 14 years old. That's why it's important to include this age group in our focuses in gender-based violence, because they are girls, young girls, and also boys. The group of 15 to 19 years old, we have at least half cases compared to the 10 to 14 years old. And we could find that 58% the youngest were Black, 29% white, the same similarities for the other age group, 15 to 19. And the great, almost half of them, so committed by family members, someone closer to the family or intimate partners. Think that 10 to 14 years old, part of those girls reported having an intimate partner. Okay, and in Brazil also it is, it's not allowed, no? And the other group, 15 to 19, 45% committed by strangers. But the home, now the should be the safest place for a child. No, it is the worst place for sexual violence. And 45% with repeat story, no, 10 to 14, and 26% with repeat story among those 15 to 19 years old. So some difference in this kind of profile. Next, please. Here, what we did here, we integrated live birth system with rape reports. Okay, why? Because in Brazil, abortion is illegal, but abortion, now by rape, it is legal. So we started to analyze if the law was applied to everyone. Now, what we found among these 32,000, almost 33,000 cases between these 10 to 14 years old, we found almost 2,000, so 1,800 resulted in a live birth. So they didn't have any access to legal abortion. And in the other group, 15 to 19 years old, more than 2,000 resulted in live rapes, okay, resulted in live birth. And between this, those two groups of young girls, no, you see that 73% among the 10 to 14 years old were repetitive. So it's a child living under violence all the entire life. That is it. And the other group, 44%, had repetitive characters. It means that those girls, they leave the home, they leave the house. When they get 15 or 16, they leave the house. So because they cannot live, they were living under this sexual violence for a long time. That's what we have to pay attention in our health services. Now, we see that those girls came into a hospital. 99% of births in Brazil occurred in hospital. So they came into a hospital, they were under care and no one realized it. That was a result of a rape, and those girls had the right to a legal abortion. And it is repetitive. So they are living under violence. And we, health service, we just look at the problem and didn't see anything. So this analysis to show it, to show the problem is under our nose and we are not noting it. Next, please. So after this, we started this violence and mortality. No? And the proposal is that this notification of cases extends the safety of the woman and their life as well, because the life is threatened. So next, please. So this analysis objective is to explore mortality risk among women exposed to violence during the period 2011 when we started the system, 2016, the year that we had all the information closed to integrate. So why just women, 70% of all violence notifications, to provide evidence to foster debates and discussion on violence-related issues and direct additional investigation and analysis. And at the end, of course, intervention. Next, please. Gender-based violence and mortality, so data sources used, of course, population, no, census population, official mortality registry, that is the SIM, it's our mortality information system that belongs to the Ministry of Health. Violence notification data that I explained to you, the Viva system that is in Jina, it's a system, an entire system for notifiable disease, and for us, violence, it is a notifiable event. And domestic product, gross domestic product, of course, GBG to control for some economic level. So it is a longitudinal study because we started in 2011, 800,000 violence notifications. Now 16,000 associated deaths reported by CRVS system between 2011 and 2016. So I took 800 cases reported, no? In this period, 2011-2016, I went integrated with the mortality data and found that 16,405 women died during this period when they have at least one notification of violence. So to minimize bias, we did 2 periods group, no? 2011-2013, 2014-2016. Next, please. So here just a summary, okay? It's a small, so you can get these slides, but just the years, no? So first level variables, year, now 2 periods, indicators, so mortality rate, exposed group, which is, who is the exposed group? Women notified by violence. Mortality rate, population level, women's mortality ratio in the country, risk ratio, and the number of deaths per year to we estimated the excess mortality and actual deaths is a accrued rate. So the causes of death, all causes of death, so communicable, maternal, neonatal, and nutritional disease, NCDs, and external causes. So the big groups of burden of disease. The type of violence, you can see all types, physical, psychological, sexual, self-reported, offender, partner or ex-partner, no, self, no person, or unknown, and the age groups, and the race, no, and the socioeconomic status, and also the civil status, no, so living union or not. Okay. Thank you. Next, please. So here we have some results. So one summary of this result, it means compared to general population, Women exposed to violence die at a rate 8.3 times higher during the period of 2014-2016, and 5.3 times higher during the period 2011-2013. It means, is violence increasing or the information is getting better? This means an estimated 100 women died from any cause on a weekly basis due to exposure to violence during the period of 2014-16 and 40 during the period 2011 and 13. Next, please. So we found a high mortality risk was associated with the physical violence and violence that involves repetition or is self-inflicted. Violence was also associated with multiple causes of death, NCDs especially, beyond those most directly related, no self-harm, interpersonal violence. When the cause of death involves external cause only, and I mean external cause, transport, injuries, unintentional injuries, and self-harm and interpersonal violence, the risk of mortality increases 51 times. The risk of mortality from all causes in women aged 10 to 19 years and 23 times higher than that of the general woman population in the same age group. And for the woman in 30 to 59 years old, now we found that they died, 26 of those women died weekly because of the exposure of violence. And when the cause of death involves external cause, the risk of mortality is most significant in women aged 30 to 59 years, who died at a rate of 12 per week during the period 2014-2016. Next. So this mortality risk is lower in women living in union when compared to those in other marital situations. When violence involves a partner or an ex-partner, and when it is self-inflicted, women at greatest risk are those in the age group of 10 to 19 years, followed by those in the age group 20 to 29, so the youngest. The mortality risk of women living in union is greatest in this group 20 to 29, 14 times that of a similar general woman population. So in the period of 2014-16, nearly 7 women aged 30 to 59 years died on a weekly basis because of violence, involving a partner or an ex-partner. When it's self-inflicted, the risk of mortality is higher in women living in union, especially associated with psychological violence. Among women living in union, the majority of deaths due to violence occurred in the age group of 30 to 59 years old. Next, please. So this is an investigation case. So you understand, so we have mortality system, we have a notifiable disease system that violence injuries are reported by health service. We integrated those data to find the status of those women who died, who is alive, and the cause of death, if you ask that. But the system also is a mortality surveillance system. So all women in Brazil that died in the age of 10 to 49 years old, it is mandatory an investigation. All states and municipalities, they have to investigate 80% of those deaths because a young woman don't die. They don't die. So it's an exception, no? So this case was this girl, Aline, of course not the real name, Brazilian, 34 years old and Black. The cause of death, according to the coroner, was Y31.4, which means impact of a motor vehicle undetermined intent on a street and roads. Okay, next, please. So the investigation, next. Next. First step of investigation. Did she have a violence notification? Yes. In September of 2015, she suffered physical violence, body force beating from the spouse, notification by the primary care unit. Next. Next, please. So she was living in abusive relationship with a man. Next. Next. Yes, so after he beat her, she leaves the abuser and starts a new relationship. So she changed her life. Now, the investigation talked to the family, especially the mother, now talked to the neighbors, all the witness, the violence, and also they told the mother that she left him because of this violence. Next, please. Next. So in February 2016, so months after the notification, now she was walking with her new companion on the road in the neighboring town. So just walking from one city to small cities, now to another. There is a park between them and so on. So next, please. Next. So she was hit by a motorcycle. Her companion survived. No, but when we investigated the case, he told us that motorcycle, the driver came back, hit her, came back and hit her again. Next. Aline died in the hospital in March 2016. Next. Next. So conclusion of the investigation. It wasn't an undetermined intent death. It was an assault by crashing of a motor vehicle on a public place, street and road. This code Y03.4 means it. So in the system, in the mortality system, we switch the cause of death. We have into the system a mortality surveillance module of investigation. So when we document all cases investigated and justify switching the underlying cause of death. Because in this situation, police wasn't interested in investigation. They believe it was an accident. The coroner classified undetermined intent. No, didn't know if it was an accident or maybe a suicide, who knows, no? At the end, our investigation means how mortality surveillance people started this investigation and found out that was an assault. And we started to negotiate with police to change the legal process, not for murder, not for injury by an accident or undetermined intent. It's important to pay attention that part of these cases of women dying, victims of violence and dying by supposed accidents or undetermined intent, it is in fact, they are victims of gender-based violence. It is in our investigation that we did, we found that. We found the case because we talked to the families and neighbors. We apply a tool, it's a verbal autopsy tool to explore of this situation. And also we have another tool to go to the forensic institutes and capture the reports of coroners, also the police reports, to have a group of information, evidences to document the case and propose to switch the underlying cause of death for this case. So we are trying to keep our statistics, no? It's a real statistic, not tricked statistics. So the next, please. So this analysis provides evidence to suggest that violence carries a considerable risk of mortality directly, to violence and act itself, and also indirectly through the development of multiple medical conditions. Think in the example gave you about the salt and hypertension. So that's women with hypertension or diabetes that we cannot control, thinking in domestic violence. Think about it. That's depression, that's not solved with anything. So they don't report the case because they are afraid. Also, physicians are afraid to ask and know more. So if I don't offer any solution for physicians, so, or for the nurses or for the community agents, look, report it. And we have a policy. So also in Brazil, we have a flow to notification of this kind of cases and action the public prosecutor, no, to protect the woman. Is it working? No, you can see by the results. It's not working well. So it's really difficult to implement this kind of a policy. This individual notification record provides this comprehensive information about every event. Analyzing these details, we can make this case, no, and make it this advocacy to correct the flows of these cases. Also, try to, with the local level, build policies that I will show you. Next, please. So we are ongoing work now as vital strategies, now with the data linkage in 2 federative units in Brazil: violence surveillance system, mortality system, hospitalization system, and probably more. Police system as well, reporting and also social work. Under victims trajectory and the health, so you build a cohort. No, we built a cohort since 2010 until the last year. No, learning from the experience with died women, victims of violence, defining priority to an urgent strategy to protect alive victims. So flag, no risk, we see which is risk, flag the situation and have interventions. Identify problems on the data collection and systematization to improve information. Next, please. So take home message: in Brazil, women exposed to violence have an estimated mortality risks nearly 80 times higher than the general woman population, and 100 deaths per week as a direct and indirect consequence of violence. Every woman exposed to violence will experience an increasing risk of mortality. Building surveillance systems, the result of a careful analysis of mortality data disaggregated by gender and investigating the death of women, especially in reproductive 10 to 49 years old. Next. So this is the reference, some papers published about these results. Next, please. And thank you very much for this opportunity in showing this public health policy to prevent and to promote health, to prevent violence and promote health. Thank you.
Well, thank you very much, Dr. Marinho and Drs. Jina and Stangl as well. We now have an opportunity to take some questions, and I'll be introducing a few of those questions now for speakers. So let me ask colleagues to rejoin. Thank you very much on the screen, and we will we'll take our first question. So the first audience question is, maybe I'll ask this of you first, Roxy, and then also of Fatima and then Anne. So the question is really, what are the biggest barriers and challenges or pushback that's received when developing gender-sensitive and gender-transformative policies as received from policymakers? So what are the challenges or barriers to introducing those sorts of policies from a policymaker perspective? Any tips for overcoming those challenges? So thanks, Roxy, first to you.
Thanks, Joe. So I would say it's a range, some of which I mentioned on the, in my presentation already. Some maybe, so firstly, I want to say that often governments don't push back. They acknowledge that gender is important and they acknowledge that it needs to be included. But I think that acknowledgement is then not seen in the documents itself, as I reflected in the, in the South African example. So firstly, just mentioning that as a starting point. I think there are a group of countries where, because of various reasons, because of laws, there are sensitivities around gender. So I think that's one aspect of it as well. Then thirdly, some topics don't, so especially for us in terms of the D2P program, some topics don't lend itself to gender. So it may be a topic that's very focused on males, very specifically, because of the type of topic that was selected. And that's referring back to Anne's comment around looking at the topics and thinking about that earlier on as well. And then I think it's sort of the underlying challenges related to developing policies and strategies. Having worked in government for very long, I sometimes think it's like death by strategy. You have these like long documents that everyone works on, but very few people look at afterwards. And I think in the development of these big documents, sometimes as you have multiple voices influencing issues, the gender component may then get lost in that process. And so I think as I mentioned, having governments recognize that it's important, not only in terms of gender sensitive, like mentioning it in the document, but also recognizing that they have to address then the issues related to it is an important factor, and then building capacity within governments around gender mainstreaming. Thanks.
Thank you very much. Maybe I'll turn to Dr. Jina, or sorry, Marino. Let's go to Dr. Marino.
I will tell about my experience, okay? Because I'm from epidemiology field and health surveillance. And gender is part of our work because we found out that it is a public health problem and has a huge impact in the women's health and increased risk of death. So that's why it became a question for health surveillance. And politicians, in my experience, the first thing that they drop is gender and race issues. Oh, but simply, poverty is okay, no equality, and so the blah, blah, blah. But when we face these issues of gender and race as well, it's really hard. So we have to build your basis. No, what I presented, it is years of work, but we start without nothing, just improving quality of health, cause of death. When we start to improve the quality of cause of death, we found out that many women's murder were, the cause of death were unknown. Unknown. So someone in a local agreement, when we start this investigation in small cities, countrysides, everyone know about the case. And people start to tell us. So we had to create a flow with public prosecutors, even to create a protection for ourselves, our investigators. So when we start to make the case, we make a case. So look, we have this situation, and those causes of death is hiding the real problem. And when we extended this also to start to with the NCD's deaths of young women, so also we found out the violence. So we built our case before. We advocated that we have to increase our capacity of intervention, and we need to improve information. So, and have this kind of system notifying. Now, what we are trying to have health services also part of this public policy, not just a security or in general policy, but health service has a role to play because those women and children, they come to health service. And we miss this opportunity to protect the people that we are paid to promote health and prevent disease. So that's why we use this, and the integration is just to call attention of them. Look at you fail here. That it is important for actions. Now, we are just talking about public policy while people are dying and suffering, thinking that children suffering sexual violence the entire life. Now, that's what we have to do, and we cannot give up. If I work in a small place, I can do something. Yes, I can. That's not exact public policy speech, but it is based on the experience.
Well, thank you very much. I see we have a number of additional questions, so maybe I'll transition from that question and move to you, Anne, with another question. So you described gender transformative policies as those that seek to change the root causes of gender equity, equality. Can you give us an example of a gender transformative health policy?
Sure. So actually, this example is from Brazil. I'm not sure if you're all familiar with an organization called Men Engage, but it's an organization that works to challenge gender norms, and specifically they implement programs to promote gender equitable, nonviolent, and engaged concepts of manhood. And there's a lot of outcomes they're trying to shift, and a lot of it is related to violence and other things. But specifically, so in addition to their programmatic work, they also work with advocacy and community groups to sort of push for more structural changes. So one example of that is in Brazil several years ago. They worked to expand or to push for a bill that it would expand the leave policies following childbirth to include 30 days of paid paternity leave. Whereas prior to that, fathers had no potential paid leave they could access. So ultimately, I was just looking this up to confirm, but ultimately, it looks like fathers are now entitled to up to 5 days of paid paternal leave, and an employer can grant an additional 15 days of paid paternity leave. But that's better than nothing, right? So I think that's an example of a way in which a country or a government, state government, or whomever, I know California has done this as well, is to sort of codify this in law to make sure that men are also able to access that time when a child is born to help out, to bond, and all of that. And so this type of gender transformative policy will hopefully shift the underlying norm that is commonly held that women are responsible for children and child rearing, and men are not supposed to be involved in that, and ideally increase men's participation in raising their kids, which will hopefully lead to less violence and more and stronger connections in the family. So I think that's a good example of what gender transformative policies are trying to do. You're trying to look at those root causes. And in this case, it's just norms about who should be raising the kids, and then actually put something into policy to help to change that. Now, of course, you can't just have a policy. You have to have support for employers to, implement the policy and understand why it's important. And you have to encourage men to actually take the leave, and all of that will go along with that. But I think that's a good example of what we're talking about here.
Thanks. Let me turn that question to you, Roxy, and just see if you have any additional examples that you might want to share of gender transformative policy changes.
So it's actually interesting because I wanted to include an example of a gender transformative policy, and I was like, oh, that's easy. I'll go and look at HIV in South Africa, because having worked in the space, I knew that there were a lot of interventions on the ground that sort of recognized the role of gender in HIV transmission and were addressing it. But when I went and actually looked at the documents, and I must be honest, I hadn't looked at them in a while, I would say that they also fall into the gender sensitive category, where they sort of speak to the issues around gender, but then don't actually, especially in the policy document, don't actually address these. So we may be seeing things on the ground and also maybe through research, but not actually, it's not captured in the policy documents. And that's what made me think about, talking about this the challenges that we may talk about gender a lot, but not actually enforce it in the documents itself. And I think similarly, I was thinking about occupational health. We often talk about, differences among, related to sex and gender in occupational health, but I don't think it's captured as well as in terms of policy. And then I looked at a document that came out of the OECD, which looked at gender mainstreaming across OECD countries. And although there were a lot of examples from high-income countries, there weren't many from low and middle-income countries, at least within OECD. They also made mention of Mexico, and I must say I haven't worked in Mexico, so this is just from what I've read in the report, where budget allocations are also linked to gender equality, and they sort of track on this and report on this. So there's specific funding in terms of policy and government's policy that's related to a budget allocation. And we've seen this as well, similar concept in Philippines as well. So just some examples. I don't think I have a great examples, but we're seeing efforts towards that. Thanks.
Well, on that note, Roxy, I think like one example of what you're talking about is like conditional cash transfers to sort of prevent young adolescent girls from marrying. So ideally, that's going to help them be less likely to be infected with HIV, or less likely to have complications in early childbirth, that sort of thing. But ultimately, it's just a Band-Aid, because those women just wait 2 years, they get their conditional cash transfer, and the research shows they just get married then. So it's not. That's not transformative. It's not changing the underlying norms that like women should be able to go on and have their careers and do whatever they want. And that doesn't have to be the end all be all option for them is marriage. So I think that's what you're getting at, because like you would think that HIV would have so many examples of gender transformative policies, but I think you're right. It's more gender responsive perhaps, but not to the level of transformative.
Great, well, thank you for that. I think we have time for perhaps one more question, so I'm going to direct it to Fatima. The question is, how might you or would you take your comprehensive data analysis of gender-based violence in Brazil and use it to develop gender-responsive policies on behalf of women, girls, and gender minorities? So how do you translate data into policy from your perspective?
Good question. Look, we have 2 pilot studies. One in one city, we did the data integration. We discussed with them the results. So we flagged the risk factors. So in this city, we have 22,000 reported violence in 10 years now, and 800 died. So we start to study the death, the causes, of course. We found out what I show you, some accidents that were murder, and also chronic disease. And we start to flag the risk for severity and death. So they can protect who is alive. If he has the same characteristics, like repetitive violence, it is risk for death. So protect who has repetitive violence reported. No, because we can identify, also we have the address. We can do something. If you don't do, it's because we don't want to do anything. Because we can do. So we flag this to them. Also, we start to flag the protection. So women that we accept to be reported to police, they survived more than that women that didn't want to be reported to police and public prosecutor, because adults, they are allowed to be reported to police and public prosecutor or not. Children is mandatory by law. So have to report all violence against children to justice system. But who accepted survived more than who didn't? Other risk, if she has a child, it is a risk, because we have live birth system. We can see if she has a child, we can see it. So, and we found it, we found that if she has much more difficulty in leave this relationship because of economic, no? So she has more difficulty, so she needs protection. Also the child died. It's really sexual assault, child, and death. It's related to those women as well. So we know a lot. No, so we are building with them an intervention. Now we are piloting now in a state, because the state, the governor is the only woman governor in Brazil. She has the control of the police. Police in Brazil is a state. It's not a federal or municipality level, but state level, they control. So now we integrate with police data as well. And we'll build the same flag, a panel, a dashboard with flags of risk, who is at risk now, what to do to improve the primary care report, how to protect the health workers, because they are threatened as well when they report. No, so it have to build intersectorial intervention. So I needed this information mapping the problem. No, identify who is at risk now for severity or life risk, and build this intervention with them. We cannot arrest all men. There is no enough. It's okay. So it's impossible. It's too much. So what to do with this situation? No, and who we have to arrest because it's really a risk for women or children. No, so these discussions have been done with the stakeholders. No, and when we have mapped all, we will start with designing the interventions, because we apply for more funds from other agencies to help EIs to design the intervention and start this intervention. It is a essay of public health, but it is possible to do. It's not impossible. It requires a political decision, and it is done. No, now we built the case, we showed the problems. We can save more lives here. We can save them. We can take those girls from that violence, repetitive violence, sexual violence. We can do something. No, if you don't do, it's because we are not committed. Oh, we got kind of governments. So we work also with the civil society. It's important, civil society, as important communication, media as well. Because we created the situation. Was good because in the city, we launched the results in a public event. So also came a public prosecutor, judges, some judges in high position, and they said, okay, we can do together. So all women, no, but we can do it. So never give up. No.
Thank you. And did you want to say something, or I see your hand is up?
Yeah, I just wanted to, one thing, and this isn't from the gender perspective, it's really more from the stigma perspective, which is where a lot of my expertise lies. But I think I just wanted to mention that, like, one of the most important ways to sort of get to the policy stage is to engage with policymakers. So you have to get the research that Fatima and team are doing into the hands of the people who can actually do something about it, in terms of not just interventions, but in terms of, structural level policies. And we did a lot of work on this with HIV stigma in countries like Vietnam and others. And one of the most important steps was getting those government stakeholders on board. And that often requires literally training. What is, what in this case, what are the gender biases? How do these biases influence health? Why is it important? And then also, like alongside advocacy groups, it's a whole effort to make sure that that data gets into the hands of those policymakers, and then their constituents are pushing them to actually utilize the data and make a change. And I think that's where the D2P program comes in, is helping public health professionals in countries to be able to prepare those really important policy briefs that take that data, that very complicated data, and pull out a few key points and share that with the government or whomever to be able to kind of have those talking points, work with advocacy groups, and sort of keep beating the pavement until you get the policy change you want. So I just wanted to end with that, because I don't want people to think that it's hopeless. I think there's a lot of ways in which there's a lot of good examples of gender transformative policies, or policies from the HIV field in terms of like gender and sexual minorities and everything. And so I do think that I wanted to end on a positive note to say that that's one way we can do this, is to really like make sure that we take the research findings and get it into the hands of the policymakers.
Well, with that, let me thank all three of you, Dr. Marinho, Stangl, and Jina, for joining today and sharing your work, and really important work that you're doing. And thank you to our audience for your really interesting and important questions and your participation. I'll now hand it back over to Dr. Kaufman to close today's session.
Thanks, everyone.
Thank you, Joe, and thank you again to our panelists. This is definitely a very challenging aspect of the work, but I think when it's successful, can have great impact. So I want to thank again our panelists, and also the CDC Foundation for their contributions to this work, and the Data to Policy course. Unfortunately, they were not able to participate today. We hope today's seminar started you thinking about using health data to develop gender responsive policies and improve health outcomes for all people in your work. We are asking Data for Health partners to spend the next few minutes taking a brief knowledge check on the materials presented today. This will qualify you for a gender equity certificate at the end of the seminar series. The knowledge check is offered in English, Portuguese, Spanish, and French. You can scan the QR code in the slides on screen or use the link in the chat. The Zoom webinar will stay open for the next 10 minutes in case you have any problems accessing the knowledge check. Otherwise, we hope to see you in 2 weeks on Wednesday, the 4th of May, 9 a.m. Eastern Standard Time, 1 p.m. Greenwich Mean Time for the final seminar in the series, CRVS Legal and Regulatory Review, Best Practices Using a Gender Lens. Thank you all.